Welcome to QD Clinic, brought to you by RheumNow.live, a great new meeting for rheumatologists. You can register and for free if you want to watch it from home. Check it out. Today's case from the clinic is Shingles happens. A 71-year-old male who I've been following for a few years who has psoriasis, pretty bad, psoriatic arthritis, pretty bad, previously taken a TNF inhibitor and about 5 months ago switched to ustekinumab. Done really, really well. Skin and joints really just doing fabulous. But 3 weeks ago, he comes down with shingles. Right side, dermatomal, really severe, blistering lesions, a lot of pain. Didn't call me, went to his primary care, was managed with Valtrex, and is now going to pain management because of the severe neuropathic pain going on for 3 weeks. This is a disaster. It happens in the elderly. It's really quite significant as far as morbidity goes. It's something that patients really dislike. And could this have been prevented? It could have been. He was not given a shingles vaccine prior to this, and we'll review that in a second. So he's dealing with 3 weeks of 9 out of 10 pain, burning, numbness, shooting pains. He's got a lot of numbness. He might well be left with postherpetic neuralgia. And again, how should we have handled this maybe going forward? Well, in my experience, that most of my patients who are getting shingles vaccines, it's being brought up by their primary care doctors. It can be brought up certainly in the rheumatology visit, and it should be your responsibility if they're going to go on a drug, especially a JAK inhibitor, and where the risk goes up significantly. So what are the risks? Who's at risk? Clearly those who are older. You know, it starts when you're 60, it gets higher when you're 70, it's really high when you're 90, if you live that long. And clearly the drugs used to prevent this, either the Zostavax or the new Shingrix vaccines, are indicated after the age of 50. But insurance companies will only usually pay for it after the age of 60. So that's when the discussion should be had. Patients who are immunosuppressed. I don't particularly view my patients on a TNF inhibitor or an IL-17 inhibitor as being immunosuppressed. I think their inflammation drives their risk. So what are the real life risk numbers for people as they get older? Normal people in the population, the risk of getting herpes zoster is about 5 cases per 1,000. Osteoarthritis patients, meaning those who are older, it's about 10 cases per 1,000, 1 per 100. Rheumatoid arthritis patients, it's probably less than 15 per 1,000. It's a little bit higher, but not that much higher. Rheumatoid arthritis patients on TNF inhibitors, it's also not that much higher. It's about 15 to 17 per 1,000. The highest numbers are seen in severely immunosuppressed lupus and severely immunosuppressed GPA patients who are taking cyclophosphamide, high-dose steroids, etc. There, the rates are somewhere around 45 per 1,000 patients. And that's about the same rate that you see with the JAK inhibitors, where the rates are about 35 to 45 per 1,000. So clearly going on a JAK inhibitor increases the risk. I don't know that going on other biologics substantially increases the risk. Certainly it might be higher when you're using cytotoxic agents or when you're having someone go on rituximab. The numbers could in fact be higher. The question is, if you have someone at risk, what are you going to recommend? Again, the old rule was to use the live virus vaccine, Zostavax, and the rule was that you need to be off of a biologic for 2 to 4 weeks, preferably 4 weeks, give the vaccine, and then restart the biologic therapy like a TNF inhibitor at least 2 weeks later. So there's a period that you must be off. If someone's never been on a biologic and you want to give it, you give the vaccine, you wait 2 weeks, you can start the new therapy. Again, those at risk where these rules are in place would be for biologics, especially TNF inhibitors, but all the biologics and also the JAK inhibitors. Does that apply to methotrexate, hydroxychloroquine, sulfasalazine, cyclosporin, or Reva? No, it doesn't. It turns out that regular oral DMARDs, you can go ahead and give live virus vaccines without impunity, right? But now it's a new era. We have a new shingles vaccine that's not live. It's an inactive virus. It's 2 shots, have to be given 2 to 6 months after the first shot. It's about the same cost as the original Zostavax vaccine, which is almost $300, $320, something like that. And it's the difference here, though, are substantial. One, you can give the live virus vaccine to almost anyone, including people on biologics, although that research has not been done There does not appear to be any new signals. And that drug has been out there and selling really, really well for a long time. We've not heard any disasters of the adjuvant inactive virus vaccine, the Shingrix, causing reactivation or worsening of lupus or RA or whatever the underlying inflammatory disorder is. So you can give it to people who are on DMARDs, oral DMARDs, conventional DMARDs, and even on biologics. We've done that, but again, there is no formal guideline that says you can do that. That's just my experience, my recommendation. I know there are others who are very concerned that the manufacturers of Shingrix haven't done their due diligence in doing studies in our immunosuppressed patients, and I also chime in and say they should. They're getting off easy by not doing it. But until such time, we're going to have to go with what seems to be best based on what we know of the drug and of the patients. So I would recommend that patients who are on or going on more advanced therapies, biologics, and the JAK inhibitors or other small molecule inhibitors be given this after the age of 60, especially if it's going to be a JAK inhibitor. Definitely after the age of 70. My guy was 71 years old. And again, it's easy to take. There are more side effects with the Shingrix vaccine. Nuisance side effects, flu-like symptoms, myalgias, feeling crummy, that sort of thing. And that's probably from the adjuvant. I haven't heard of any patients say it was horrible. There have been about 10 to 20% of patients who are complaining of some symptoms. I guess the other thing that you need to know is the Zostavax was a good vaccine. It lasts for 4 years. Its efficacy waned with the increasing age of the person receiving it. So it was much better when given to 50 and 60-year-olds than to 70 and 80-year-olds. But the Shingrix vaccine, the newer vaccine, is far more effective, doesn't wane or change with age, doesn't change as far as protection against post-herpetic neuralgia as you get older. That's why it seems to be a superior product. So think about this when you're faced with the issue of shingles in your patients. More tomorrow on QD Clinic.